going through what endometriosis is, the signs, symptoms, the treatment options, and basically what you need to know about it. So if you bring on Dr. Raja, please. Hi,
Hello,
Dr. Raja.
Sulthana.
How are you doing?
How are you? I'm really well, thank you.
Good, good. So I have the privilege of actually knowing Dr. Raja through social media. Thank you so much for joining me on this platform. If you could introduce yourself and tell us a little bit about what you do.
Yeah, so I'm a Birmingham-based GP, and as you know, I'm a general practitioner. I see lots of women with lots of health conditions on a daily basis. Endometriosis is a topic which is very close to my heart because I have suffered from it because I was a gynecological disaster myself most of my life. So I thought it's a good idea to perhaps have a little discussion on this topic.
Yeah. I mean, it's not absolutely necessary, but I do find that it sometimes helps when you've gone through something similar yourself and you can relate to the patient on a different level. So I am going to crack right on, and if you can talk us through what endometriosis is, that would be great.
So endometriosis is a very common condition, but it is surprisingly quite difficult to diagnose in the sense that it can take up to 7.5 years, 7.5 years for a person to get a diagnosis on an average. Now, what is endometriosis? Endometriosis is a condition where the lining of your womb, the cells of your womb, start growing elsewhere in the body. So essentially, what tends to happen is that whenever you have a period, instead of you just having the pain inside your uterus, which is your womb, you can have pain where the endometriomas are, which are these little deposits of the cells of the lining of the womb elsewhere in the body. It could be in your bowel, it could be around your bladder. So essentially, a woman who suffers from it is in a lot of pain.
And I mean, it sounds quite bizarre, isn't it? Like the endometrial tissue being deposited in random anatomical locations, although they do tend to center in the pelvic area. Are you able to shed light on what causes it? Do we know why women get these endometriota everywhere?
Yeah, in my case, Sultana, it's quite interesting that I had a myomectomy at the age of 15.
Wow.
So we believe that there was some sort of spillage that potentially happened at that stage, which deposited a couple of the endometriomas in near my navel area, which we call the umbilicus in medical terminology. So that was the reason why I got my endometriosis. However, they say that it could be when the periods are actually moving backwards, like not coming down. We call it retrograde menstruation. Again, you know, it could be surgery, an aftermath of that with some spillage here and there. It is something that I believe cannot be avoided if you are suffering from it, or if you are going to suffer from it, which makes it slightly more complicated, I guess.
Yeah, and just to add to what you said, there will be many cases where actually there is no identifiable cause or reason, and it's just one of those things that seems to happen in your body. And the other thing that I know some of my patients have noticed is that it tends to run in families, so you are more likely to have it if your mum or your sister, aunt, etc. suffer from it as well. And so you have kind of talked about pain and things like that. Can you go through the types of symptoms that a woman might suffer from if she has endometriosis?
So you see, what we essentially tell our patients, and something that we believe ourselves as well, is that when you have your periods, you can have some period pain, some discomfort, some amount of bloating, but it should be very mild. It should never be moderate to severe. So if you've got period pains which actually take over your life, which are severe to moderate, if you feel that you have bloating, that you have some bowel symptoms where you're getting more constipated, or if you feel that passing urine becomes more painful, if you feel that, you know, you're with your partner, you're having intercourse, you're having sex, and that's painful, then these could all be signs of you actually suffering from this condition.
Okay, brilliant. So a lot of women or men may think, well, periods are a natural form of, you know, it's a natural process. It happens every month. Surely you should be kind of used to a level of pain and discomfort. But yes, exactly as you said, what we say to our patients is actually it shouldn't be so severe that it affects your quality of life or your ability to actually function and do the things that you would normally do. And lots of women do find it quite disabling, don't they? Because they might have to take time off work. It's that severe. Have you had much
It
experience with really severe cases?
Definitely. And Sultana, because I suffered from it myself, I was really young. I was 17 when I was diagnosed with it. I mean, I was taking my A levels at that time, and I had to take a lot of time out of education because of that. I had to go to, I mean, it was quite surprising that I actually met a radiologist who was really good. So my diagnosis didn't take that much
Yeah.
time. So I was diagnosed within the 2 year period. But being a sufferer myself, and seeing all these patients that come to see us, the most difficult bit is when they're working in an environment where people don't understand the condition and there's lack of compassion, and they do need to take time out of work or they cannot work. That puts them in a very tricky, difficult position. So, and especially for young mums, who have 2, 3 children, who have to do school runs, who are working at the same time, it really, really hampers your life. And it has a major mental impact as well on your mental well-being, on the way you feel about yourself. It affects your relationship with your spouse. I think it's one of the most debilitating conditions, and it is one of the second most common gynecological condition.
Yeah, so it's definitely more than just really bad period pains.
Mm.
And I think that's the point that we both want to kind of labor on, is that it's just not just a case of pain. It affects many different aspects of a woman's life. And then the other thing I wanted to touch on in terms of symptoms is it does tend to affect women who are of what we describe as the reproductive age. So women kind of from their teenage years into their mid-30s, they are generally the people who suffer from endometriosis. And sometimes it can impact on fertility as well. Are you able to talk a bit more about that?
Yeah, definitely. I mean, it's quite interesting. I was reading a paper, and it was mentioned that when they were doing workups on women who were unable to conceive and were within the reproductive age, which Sultana has rightly highlighted, the outcome was that 30 to 50% women who were unable to conceive actually suffered from endometriosis. So it can actually be, a major setback in terms of fertility as well. So it is very important that we sort of diagnose it as soon as possible. And we try not to take 7.5 years before we actually diagnose someone with endometriosis. Because you can imagine if somebody is, for instance, not planning on having kids up until they're 30 because of university or work or whatever in life, and then they find out that they actually have endometriosis and it takes them another 7 years to diagnose that, it can have a major detrimental impact on their life, on the way they're planning life, on their ability to have kids.
Yeah, yeah. So that is, yeah, an excellent point to highlight. So let's say a woman is suffering from really painful, heavy periods. She finds them quite debilitating, quite serious. What advice would you give her? What is it that she should do?
You should definitely speak to the general practitioner, contact your GP. Your GP is more than happy to listen to you. And it's very important that you contact your GP rather sooner than later. If your periods are stopping you from leading a normal, healthy life, then you definitely need to speak to someone. And your first point of call, of course, is going to be your general practitioner. And I would also strongly advise that when you speak to your GP, do mention that you are actually thinking of endometriosis and ask them that question, because sometimes it is important that you prompt your doctor and actually ask them if this is something that they are thinking of as well, given your symptoms.
Yeah, so that's a really good point that you make about essentially what is self-advocating of,
Mm.
I think as a GP, we are very used to patients having Googled their symptoms. They usually speak to their friends, family, before they come in. And we usually do want to know what your ideas or concerns, what you're worried about. So yeah, definitely we would want to know about that as well. So what we want to talk about next, if that's okay with you, is what do you think, or what should the patient expect from the initial GP consultation?
The most important thing to expect is the next step. So when you speak to your GP, I suppose the next step is to sort of see how we go. If this is a new symptom, for instance, your GP might want to see how you go the next 3 cycles. That's what we usually do. If somebody comes with us and says, well, doctor, I'm having these new painful periods, for instance, what we would like to see is this a continuous pattern? Is this a continuous thing? Or is this just like a patchy pattern of something that's happened and will get better with time? So it is important that you have this sort of rapport with your GP, you have a good discussion, you tell them everything about your symptoms, your sexual health. Are you having any pain when you're having intercourse, when you're having sex? Is there anything else that's happening? Are you having any bladder symptoms? Are you having any bowel symptoms? It's very, very important that you speak to your GP about this. Is this pain happening anywhere else in the body, for instance? Are you having the period pains? Like in my case, I had my period pains, but then I would have this pain which was very close to my navel area. That is where the endometrioma was sitting. So is that something that's happened? So it is important that you sort of open up, have a frank discussion with your GP. And of course, the first step would be your GP talking to you about it. And then sometimes we ask you to keep a little diary and speak to us in another 4 weeks' time and see how we are. And then, we can take it from there.
Yeah, and then just before we go to break shortly, the only other thing to mention is there may be an intimate examination involved as well, just to examine the area and see whether there are any anatomical kind of differences. That might seem quite daunting to lots of women, but let me assure you, as GPs, we do them quite regularly. And to discuss this more, we will be right back after this break. I will see you shortly. Assalamu alaikum everyone, welcome back to the Health Show. I am Sulthana Ahmed and I am discussing endometriosis with the wonderful Dr. Anita Raja. If you missed the first half of this segment, we went through what endometriosis is, the types of signs and symptoms that it causes, and how it's actually a lot more than just a painful period, and it can be quite debilitating if you have a severe form of it. If you do want to rewatch the first part of the episode, you can catch it on YouTube and Facebook. So do check out the British Muslim TV pages for that. Okay, thank you, Dr. Raja. So for the second half of the show, I wanted to kind of talk about what is it that we can do about this, or is it something that women just have to put up with? So we talked about, how women can get pain, heavy periods, they might have bladder or bowel symptoms, sometimes they have fertility issues. Many of them can develop low mood as a result of the impact of the symptoms on their lives, and they will present to their GP, who hopefully, will go through the history, maybe examination, and an ultrasound scan as well. I wanted to touch on laparoscopies as well. Are you able to talk about what that involves?
Yeah, definitely. I was going to say that an ultrasound scan may not always pick up the endometriosis, which makes it a poor diagnostic marker. So initially, your general practitioner will, of course, like to examine you. There might not be anything that they could see in the examination. That does not mean that you don't have endometriosis. And then they can also request an ultrasound scan. Now, again, this ultrasound scan could come back as completely normal, but that does not mean that you don't have endometriosis. The next step would then be referring you to the gynecological team. And the idea is that they offer you something called a diagnostic laparoscopy. Now, what is a diagnostic laparoscopy? It is basically a camera test of your pelvic area to have a little look with a camera, which gives them a direct access to have a good look and see if there are any endometriomas in that area. Because it's a camera, they can look at it directly, and it makes it a much better prognostic tool. So that is usually the next step. And sometimes while they're doing that, if they can sort of cut some bits of the endometriomas out, they would do that for you. Of course, they're going to ask you those questions before they actually do the procedure on you, and it depends on the consent that you've given them. But that is usually the next step.
Brilliant. And so let's say once the lady has been diagnosed with endometriosis, what options are available to her? What is it in terms of how do we manage it for them?
Okay, so women have two types of female hormones. One is estrogen and one is progesterone. Now, when you're pregnant, your progesterone goes really high, and that hormone actually protects your baby during pregnancy. Now, again, when a woman is in menopause, when she's menopausal, the estrogen goes down. And that is why women get, the hot flushes and the dryness down below, and, the mood swings and all sorts of different symptoms, which we call menopausal symptoms. Now, it's very interesting to know that the condition, endometriosis, is very, very sensitive to the hormone estrogen. So the idea is to either put a woman in a medical sort of menopause or put her in a state of pregnancy so that the endometriosis doesn't grow, so that it becomes dormant. Because you'd be quite interested in knowing this as well, that when a woman reaches menopause, if she's got endometriosis, it sort of dampens and dies away. So it is very, very sensitive to your female hormones, the estrogen, which would be at its peak when you are in the reproductive age, when you are, nice and fertile, ready for your babies. That is when it hits you the hardest. So the idea is that giving patients some sort of hormonal therapy where we can either put them in a state of menopause or put them in some sort of medical pregnancy state where the body thinks, all right, fine, I don't need the estrogen at the moment. And that usually helps dampen down the endometriosis.
Yeah, so I mean, in GP land, when you first present to your GP, some of these hormonal tablets are actually contraceptive pills, aren't they?
Mm-hmm. Definitely, yes.
So are you able to tell the viewers a bit more about the difference between like combined or mini pill, or is one preferred over the other?
Definitely, yes. So what we do is we've got like two types of pills. We've got the combined pill where we've got the estrogen, and then we've got the mini pill, which is the progesterone only pill. Like I've explained, we've got these two hormones, estrogen, progesterone. Progesterone is a good hormone, estrogen not so good for the endometriosis. Now with the progesterone, what tends to happen is sometimes what we do is we'll put you, for instance, on the mini pill, let's say, which is the progesterone only pill, and we have a little look at your response. And now the new guidance also suggests that we can double it. So if you are taking, say, the 75 microgram, we can double it and see if that works for you. So it is a bit of a hit and miss really for different patients. I mean, sometimes they would say put them on the combined pill if they haven't tolerated the mini pill. Then we've got the other sort of injections. We call them the depot injection, which has got the progesterone again, which is excellent. And it's got its own side effects, as in it affects your bone density, makes your bones a bit weaker. So we have to be very careful when we look at the sort of, when we decide what we're going to choose. But I think that the most important thing, there's no right or wrong way of doing this. It really depends on how your patients actually respond and whether it helps their symptoms.
Yeah, exactly. And so I think the takeaway point from that is there are, just at the GP level, there are several different treatment options available. Usually we do start something for about 3 months. We'll monitor you, see how you go, review it, and then if we continue it as it controls your symptoms, that's great. If not, we can actually try something else as well. Now, the only catch-22 of that situation is women of a reproductive age who have endometriosis but actually want to get pregnant. So what would you say their options are?
I think for them, the most important thing is to perhaps get a diagnostic laparoscopy and then see if something can be done about the endometriomas, whether we can treat them. Sometimes what I have seen that gynecologists like doing is putting them in a sort of a state of a menopause for a couple of months to see what happens to the endometriomas and how that affects their symptoms. And of course, after that, they can try for a baby. But of course, it's a very, very difficult situation. Sulthana, you've hit the nail on the head. This is the biggest problem that we face when somebody comes with these symptoms, is failing to get pregnant, wants to get pregnant, and then you tell them that your option is going on a contraceptive pill, which actually goes against the whole idea of getting pregnant. But yes, it's always worth sort of going on a treatment for a couple of months, seeing how your symptoms are, seeing how the response is, and then sort of picking up from there, because you are usually very good to go as soon as you stop the pills. With the depot, of course, it's a bit tricky. It can take a couple of months for your fertility to come back. But then having said that, really depends on what sort of management plan we've offered.
Yeah, so I think I asked that question because I've had it in GP land so many times where they want to get pregnant, and it's just not, it's not an easy decision, is it?
No.
Do you treat the endometriosis, delay trying to conceive? And I guess what I try to say to my patients is it's an individualized decision. We can have a risk-benefit discussion with myself or with a gynecologist to try and decide what the best option for you is. Because the chances are, if we manage to reduce down the endometriosis, then that will improve your chances of fertility later on anyway. But each case is individual, and you need to have that conversation with your GP and gynecologist. The only other thing I thought I would mention is we do have non-hormonal treatments as well, don't we, that we can give to patients just to try and help them control the symptoms of pain or bleeding. Did you want to talk about, like mefenamic acid or tranexamic acid and things like that?
Yeah, we can definitely do. So that is more symptom control. So we're not really doing anything about the endometriosis, of course, but it's symptom control. But I agree with Sulthana. This is why I mentioned that what I usually tell my patients is that, look, let's put you on this treatment for a couple of months, and then we can pick up from there and see how you go. Because of course, once we control the endometriosis, your chances of actually conceiving they go up and they get much better. But having said that, sometimes some people don't want to go for that option because they're desperate, because they're running out of time, they think that their biological clock is ticking away, and they don't want to give it another 6 months to a year to wait. So for them, it's basically just symptom control. We've got a couple of things that we can offer you. We've got non-steroidals, we call them, like mefenamic acid, naproxen. They reduce inflammation. They help a lot when it comes to period pains. They are magical, I must say, when it comes to the symptom control. And then we've got, medications that can decrease your flow as well. So if you're having very heavy bleeds, you're having these heavy painful periods where you're passing clots and you're soiling yourself, then we've got this medication that we can give you, which actually helps, slowing down the flow. It's called tranexamic acid, and it's a course that you take for 5 to 6 days, and it really does help. We're very limited in terms of non-hormonal therapies, if I'm honest, and they will only act as sort of painkiller and decreasing the flow. If you don't want to go on a contraceptive pill, of course, that is the option you've got.
Yeah. So, don't suffer in silence. We have hormonal, non-hormonal, GP level, and also specialist level interventions that we can do to either remove the endometriosis surgically or try and manage medically where appropriate. That is a conversation that you need to have with your GP or gynecologist. Now, really quickly, just before we finish for today, is there any lifestyle intervention that has been shown to help?
The biggest thing that should and would always help is weight loss, exercise, a healthy diet. So if you cut out a couple of things from your diet, I know it's easier said than done, but I have successfully followed a very low-carb diet since April 2019. And I promise you, if you go on a low-carb diet, you cut out your carbs, you cut out dairy to some extent, a bit of gluten from your diet, saturated fats, and sort of inculcate a much healthier diet in terms of veggies, fresh vegetables, some fruits, some lifestyle changes in terms of, cutting out alcohol if you drink, quit smoking, that definitely does help. Then it is something that does help your symptoms. Because you see, if we look at research, then endometriosis runs very closely hand to hand with IBS and other
That's
conditions.
true. Yeah.
So you will feel good about yourself, and your gut will feel better, and your bladder will feel better if you have a healthy diet,
Yeah.
if you are, exercising.
Thank you so much,
by all
Dr.
means.
Raja. That has been such great advice. Unfortunately, that is all we have time for today. Please do join me next week on The Health Show again. I'm Dr. Ahmed, and it has been a pleasure. Thank you.